Good afternoon. Really happy to be here. I was expecting to come to Switzerland and see lots of snow. We have a lot more in Boston than you have here in Bern, but it's much warmer here. So Olivier asked me to talk about sex differences in incidence of stone disease. So before we start getting into the details, I want to talk about definitions, okay? So incidence, the way that I interpret as an epidemiologist, is it's a rate, okay? So we're going to be talking about in terms with some unit of time, whereas prevalence is just cross-sectional, and I'll show you some prevalence information as well. And of course, for stone disease, if you ever have a history of stones, then that will accumulate over time. And you may hear this term cumulative incidence, which is just the incidence rates times time, and it's really quite similar to prevalence. But I'll be using sometimes prevalence, sometimes incidence, and just want to make sure that we know that distinction. So the first data I'm going to show you are from the NHANES. This is a national sample from the United States. Unfortunately, very few other countries have a truly representative sample with respect to stone disease, and as was previously shown, the prevalence of stone disease in the US has gone up substantially, okay? But we want to know about sex differences, and so we've been able to break up the data into males and females. The men are on the left, and the white bars let's just focus on because that's the most recent year, and you'll see that in men, a lifetime prevalence, so going up to age 74, close to 20% of men will have at least one kidney stone. In women, the prevalence has gone up as well, but it's actually still substantially lower than men, and the lifetime prevalence for a woman is 9%. Years ago, when I first got in this business, they said that men were 3 times as likely as women to form stones. Now it seems perhaps it's closer to 2 times, but there's still substantial differences between men and women. So I was trying to get some national data from Switzerland, and the only one that I could come across was there's an inflammatory bowel disease cohort from Switzerland, which actually was quite interesting because it's a very large sample. These people have had the disease for at least 10 years, and IBD is one of those conditions that we expect the prevalence to be actually substantially higher. But interestingly, for ulcerative colitis and Crohn's disease, it was less than 5% of those individuals had a history of stone, which actually is quite interesting. But more importantly is that 47% lower risk in women than men. Again, something that hadn't been appreciated, at least by me before. So it's not just in the whole population. There may be subsets of conditions where also there may be sex differences. So I want to tell you a little bit about the cohorts that I work with. It's some of the data that I'll be showing you. And there's 3 large cohorts. The first one is the Nurses' Health Study 1. It's 121,000 women that we've been following now for over 40 years. Nurses' Health Study 2 is 116,000 women. Again, across the US, we've been following them for almost 30 years. And then we have a male cohort, Health Professionals Follow-Up Study is 51,000 men, and we've been following them now for over 30 years. So much of the data that I'm going to be showing you now, these cohorts are not just for kidney stones. They study lots of other things, but we've been able to look at kidney stones in them. So how do we identify kidney stones? Well, we mail questionnaires to these individuals every 2 years, and if they self-report a kidney stone, then we send them a supplementary questionnaire that asks a lot more details. And we've also collected 24-hour urines on several thousand of the participants. But as I mentioned, once they report a stone, there's a supplementary questionnaire, and then we got medical records on several hundred individuals, and not surprisingly, kidney stones are very well reported, particularly by health professionals. And at least in our cohorts, the small proportion that actually had a stone composition, the vast majority were calcium oxalate stones, as we've seen in the general population. So from these cohorts, I can now tell you about incidence. So these are rates among individuals who have never had a stone before. How likely are they to form their first stone? And in the female cohorts, which is the 2 lower blue lines, you'll see in the younger women, below age 30, it starts off about 2.5 per 1,000 per year. So even though we talk about stones being common, to do these studies of incidence, you need very large numbers. But over time, the incidence rate for younger women is about 2 per 1,000 per year. In our older women, it's about 1.5 per 1,000 per year. But in the men, it's, again, substantially higher than that, as high as 4 per 1,000 per year in the 50-year-olds. Importantly, the incidence rates do come down, but I do want to emphasize even people in their 70s can form their first stone. But again, incidence is substantially higher in men than women. So that's in adults. The data in children is much scarcer, and that's because stone disease, fortunately, is much less common in individuals. But these are data from the Mayo Clinic, Olmstead County, Minnesota, one of the states. And you'll see, if you just look at the different color bars over time, that the prevalence of stone disease has increased, but it's gone up substantially in the teenage groups. All these data were based on just 84 stone formers. When they looked separately for girls and boys, actually girls had higher rates of stone formation, at least in teenagers. So with bigger studies, we're going to need to look at that a little bit more, because if it is more common in younger individuals, when does that flip occur that men are more likely to form stones? So the question that I was asked or charged with was, why are there differences in stone rates between men and women? And there's lots of potential explanations. Some of these explanations should explain why they actually should be closer together, not further apart. But I'm going to talk about dietary factors. We'll talk about non-dietary factors, urine composition, and other relevant medical conditions. And I just want to preface that Dr. Ferraro is going to be talking a lot more about diet, so I'm going to just be focusing on the differences between men and women, and he'll have the opportunity to talk more about the individual dietary factors. So someone already showed this. These are data from Dr. Dadon in France, but the vast majority of stones are calcium oxalate, smaller proportions calcium phosphate. Unfortunately, in our cohorts, we don't have stone type on every single one, so we're going to have to assume that most of what we're talking about relates to calcium oxalate stones. From the Mayo Clinic, and Dr. Malouf showed these earlier, do want to emphasize again that the stone types do differ between men and women. They do differ by age. So depending on which cohort you're looking at, it wouldn't be unexpected to see different risk factors between men and women. And again, predominantly the biggest difference, or the big differences, are that calcium phosphate stones are much more common in younger women than they are in older women, and this issue of increasing uric acid as a proportion of total stones with increasing age. So there's all sorts of different risk factors. We don't have time to go through all of them, but I do want to emphasize that stone disease is also should be considered a systemic disorder. And there's many conditions. I showed you earlier about Crohn's, inflammatory bowel disease, but there's others such as primary hyperparathyroidism, much more common in women than in men, and some of these others that gallbladder disease, cholelithiasis, are more common in women that may be related to stone disease. So as we start to tease this apart, we really need a lot more information than just any one specific aspect. As I mentioned, Manuel will be talking more about diet, but I do want to emphasize that we and others have shown that dietary associations do differ, in some cases, between men and women. So for calcium intake, with higher calcium intake, there's a lower risk of stone disease. We've found this quite consistently in our male and female cohort, so dietary calcium is not the explanation. Turns out that calcium supplements, we and others have shown that is associated with a higher risk of stone formation. And one of the, it's not just that the magnitudes of the association are comparable, but actually women are much more likely to be taking calcium supplements than men, with the idea that it may prevent osteoporosis. So the higher risk in calcium supplement the higher risk of stone formation in calcium supplement users may be one of the explanations why women should actually be closer to men, not further apart. Again, but this is going to depend on age. For oxalate, most of the stones that I mentioned are calcium oxalate stones, and we've found that there is a higher risk of stone formation with higher oxalate intake, but we only found that in our male and older female cohort. In our younger female cohort, did not find an association. Again, this may have something to do with the fact that calcium phosphate stones are more common in younger women. Okay, potassium, and then fluid, really important. I assume Dr. Ferraro is going to go into this in detail, but remember that this is a disease of concentration. Fluid intake is an extremely important risk factor, but in our cohorts, the risk of stone formation was comparable, though the magnitude of the association was stronger, so women seem to be more sensitive to fluid intake than men. I'll talk more about fluid intake when we talk about urine volume in a little bit, but when we look at dietary pattern, DASH being the most common one, we actually didn't see any differences between men and women. When we started to look at some of the individual supplements, and Dr. Ferraro published this several years ago in AJKD, for male vitamin C supplement users, and again, the highest category was 1,000 milligrams more per day. There's, I don't know about here, but in the US, there's lots of people taking very large doses of supplements for all sorts of reasons. But in men, we found a much higher risk of stone formation independent of all these other risk factors, but we did not see an association in women. Fructose, lots of reasons why we shouldn't be consuming foods that have sugar added to them. The magnitude of the association in the female cohorts, the two top lines actually seem to be greater than men. Again, though, these associations would tend to drive the risk closer together for men and women rather than further apart, but it does seem that diet plays a differential role in stone risk in men and women. So I mentioned earlier that stone disease should be considered a systemic disorder, and again, primary hyperparathyroidism is one that often comes to mind. Again, much more common in women than men, but still relatively small proportion of total type of secondary conditions causing stone disease. But one that's very common is obesity. And when we looked at this many years ago, we found that there's a much higher risk of stone formation independent of diet and other risk factors with increasing weight. This is in pounds, but the two lines that go linearly up are from our two female cohorts. In the men, the association with weight seemed to flatten out a little bit. When we look at weight gain, that seems to be the major predictor. It isn't just what your weight is, but how much weight you gain since you were in your late teens. And again, with weight gain, the magnitude of the association was much greater in women than in men. If you prefer looking at body mass index, again, the associations look quite similar. There's a much more linear association with women than with men. Physical activity not associated with risk of stone formation. Again, Dr. Frau refuted a previous publication, but once you adjust for other factors and look at confirmed stones, physical activity, which is still really important, I don't want you to misinterpret this, but not associated with stone risk. So I'd mentioned about weight, and that made us start thinking about glucose intolerance. And so we did two analyses. These were done by Eric Taylor, and we looked cross-sectionally in our three cohorts. And in all three of the cohorts, individuals with a history of diabetes, adjusting for all the other factors, also had a higher prevalence or risk of being a stone former. The magnitudes of the association, though, what you can see are much larger in our two female cohorts, both the older and younger. When we looked prospectively, there was no association between diabetes and stone risk in our male cohort, but again, a substantially higher risk, adjusting for for weight and dietary factors in our female cohorts. So I'd mentioned earlier about calcium supplements being used commonly to prevent osteoporosis. Megan Prohaska, who's a renal fellow at our institution, was very interested in the relationship between bone density, bisphosphonate use, medications that are often used to prevent fracture in individuals with lower bone density, and risk of kidney stones. So we looked within our female cohorts only. We don't have the information in our male cohorts, but women who reported low bone density, adjusting for all these other factors, actually had a substantially higher risk of stone formation, not necessarily surprisingly, since higher calcium excretion may be related to both lower bone density and stone risk. But then she looked among those who reported low bone density, those who were using a bisphosphonate versus not, individuals using a bisphosphonate actually had a substantially lower risk of stone formation. So there is a suggestion, this is observational data, not randomized at all, but perhaps that bisphosphonate use may reduce the risk of stone formation in individuals with lower bone density. We also have 24-hour urines on several thousand people I'd mentioned, and we couldn't explain why the bisphosphonate use may be lowering the risk. It isn't simply that it's reducing urine calcium excretion. So we talked about dietary and non-dietary factors. I do want to look at urinary risk factors, since, as you've heard before, and you will hear more about that, this are really the major factors that we used clinically to decide about stone risk. And not surprisingly, in our cohorts and others, higher urine oxalate and higher urine calcium associated with a higher risk, again, predominantly calcium oxalate stones. It was mentioned earlier that citrate's a natural inhibitor of calcium oxalate stones, and again, this is a disease of concentration. Volume is really important. I want to talk about definitions. Many of you have heard me rant about this before, but this idea of hypercalciuria versus not, these are really continuous variables, and I'll show you some data in a little bit that we have to be very cautious when we define people in one category or another. These are some, I put classic definitions in here. Again, these are really made-up definitions, but I didn't want to put that on the slide. But one of the important points here is that men traditionally were allowed to have up to 300 milligrams of calcium per day, and still be considered normal, and women were allowed to have 250 milligrams. So one of the questions is, why are men allowed to have more calcium than women? It's not really clear. Hyperoxaluria, the definitions were comparable for men and women. It's not clear if that should be correct or not. And again, for hyperuricosuric, there were different definitions. But what we really want to know is, how do the absolute levels relate to stone risk? I'll show you those data in just a minute. So these are data from our cohorts. We collected several thousand 24-hour urines from both cases and controls. The cases are in the light blue. The controls are in the yellowish-orange bar. And you'll see, not surprisingly, in all three of our cohorts, again, NHS1 is our older women, NHS2 is our younger women, and HPFS are the men, that the cases had higher urine calcium than the controls. Not surprising. But actually, on average, the differences aren't great. But averages can be deceiving, and we really want to start to categorize people, which I'll show you in a minute. But the other point is that the mean values are really quite comparable between men and women, okay? So men, on average, don't have substantially higher urine calcium than women. Urine oxalate, you see a similar story. The cases are slightly have higher urine oxalate. Again, the differences aren't great. But one key point here is that men have substantially higher 24-hour urine oxalate than women. And if we had to pick one of the most important reasons or explanations for why men are more likely to have stones than women, it probably has to do with the higher urine oxalate in men. I'll come back to that in a little bit. So as far as volume, I told you this is a disease of concentration, right? So I told you that men are allowed to have more calcium in their urine. So who do you think has higher 24-hour urine volumes, men or women? All right. So who urinates more frequently, men or women? So it turns out women do, but that actually doesn't tell you about the volume, okay? It has to do with differences in anatomy. But it turns out that women do have slightly higher 24-hour urine volumes than men. Not surprisingly, the cases have lower 24-hour urine volumes than controls, okay? But if you look at this, the two groups on the left, we can even focus on the controls, that the 24-hour urine volume is slightly higher in women. So this, again, is really important when we come back to the definition. If we look at men, and if we use the classic definition, if their urine volumes are lower and their urine oxalate's higher, it's not really surprising that their 24-hour urine, that their risk of stone formation would be higher. But that's what's allowed. What we really want to look at is what's the actual risk of stone formation by 24-hour urine values. And it turns out that it's not a whole lot different between men and women, okay? So these are, across the bottom is the 24-hour urine calcium. This is in milligrams per day. This is based on over 3,000 24-hour urines. We have, on the y-axis is the relative risk of stone formation. And you'll see that with increasing urine calcium excretion, the likelihood of a stone former increases. So this idea that it only happens at, say, 250 milligrams for women, you can see there, compared to less than 100 milligrams per day, their risk is almost already threefold higher. Okay, so again, we need to be careful with the definitions. And if we use the traditional definition of men, it's more than 300 milligrams. Well, that risk is higher than if you're at 250, whether you're a man or a woman. Okay? So I would try to avoid thinking about those definitions just dichotomously, but you will see that with increasing values, the risk is clearly higher, and it doesn't seem to differ between men and women. If we look at oxalate, again, the risk increases with increasing urine oxalate, not surprisingly. And if we look at citrate, the risk decreases with increasing urine citrate. And again, it's quite comparable whether we're looking at our males or female cohorts. So more recently, Dr. Prohaska, again, the fellow that I mentioned before, looked at this relative supersaturation. Dr. Maloof had mentioned this, this concept in his talk. And relative supersaturation is really just a calculated value. It's not a measured value. We would love to be able to stick a probe in and talk about the lithogenicity of the urine, but we don't have that yet. So we use these calculated values. And we wanted to look at the relative supersaturation, which incorporates all the different urinary components that's measured in the 24-hour urines that we look at, to see if the relative supersaturation differs between men and women. Again, on the left side, well, first the cases and controls, not surprisingly, the controls have a lower calculated supersaturation. Okay, it's not surprising that stone formers it would be higher. But again, if we look at, at least for calcium oxalate, in the cases it's substantially higher than both men and women. So consistent and not surprising that the risk is higher, but the main factors are that the urine volume is a little bit lower and that the urine oxalate is higher because many of the other factors are not different between men and women. If we look at calcium phosphate, the bar is much higher actually in the Nurses' Health Study too. Those are the younger women, and that actually is consistent with the data from the Mayo group where calcium phosphate, at least in young to middle-aged women, is higher. Okay. So then what we wanted to do, so those were just means. So then we took these values because lots of times you'll see that they'll say, well, if you're above a certain supersaturation, that's when stone formation starts. But not surprisingly, just like I showed you with the individual components, if we look at the calcium oxalate supersaturation, for example, in this slide, that the likelihood of being a stone former goes up, and it's not just a threshold. So one of the things to look at is that the bottom white line is at the male cohort. There's very few women that were in the highest category of 4+, so we collapse that there. But you will see, because men tend to have higher supersaturations, that their risk of stone formation again is higher. So it was mentioned previously that stone disease is important not just because it's painful, but also may be related to other conditions. And so this is, again, is a paper that Dr. Ferraro published in JAMA using data from our cohorts. And in our two female cohorts, the ones in the middle there was actually a higher risk of cardiovascular disease. But when we actually looked in our male cohort, that's in the first column, we did not see association. So there may be other factors that are playing a role here about why we're seeing differences in cardiovascular risk and also differences in stone formation rate. So fracture is another thing that is also concerned and may be different between men and women. Women are at much higher risk for osteoporotic fractures than men. Eric Taylor did this analysis looking to see if individuals with a history of kidney stones were at higher risk for fracture, and found that in our female and male cohorts, individuals with a history of stone were much higher risk for wrist fracture, but not for hip fracture. So one of the biggest questions that we get asked out all the time is, what proportion of stones can be prevented, and does it differ between men and women? So Manuel tackled this really important question and published this data just this past year. And so again, in our 3 cohorts, there were close to 200,000 individuals. We had millions of person years of follow-up, over 6,000 stones. And then the question, though, is we looked at the 5 most common modifiable factors associated with stone risk to see what proportion of stones could be prevented. It turns out in all 3 of the cohorts, the findings were actually quite consistent, and well over half of the stones, just by dealing with these very common modifiable risk factors, could be prevented. And again, I want to emphasize that this was similar for men and women. So other considerations. Well, when we start to look at other studies, I hope that they'll start to report sex-specific results, because it's clear that there are differences in rates between men and women. And some factors that are more common in women than men may be affecting the rates of stone formation, and particularly the obesity epidemic is unfortunately more common in women than men, and that may be one of the reasons that now we're seeing rather the ratio of men to women for stone formation being 3-to-1, it may be closer to 2-to-1. So what can we conclude? So it's clear that as far as prevalence, that men are much more likely to have a history of stone disease and have a higher incidence of stone disease. But the incidence appears to be increasing in women. I showed you in our younger cohort that it's now getting closer to the male cohort, that there's many modifiable risk factors that can influence the risk of stone formation. And in fact, more than half of the incident stones can be prevented in both men and women. So what can we learn from the data that we have so far? Well, it really seems that the main reason, based on the data that we have, is that it's really the slightly lower urine volume and the higher urine oxalate in men. It may sound easy to just say we're going to reduce the oxalate in men. I'll leave that discussion to another time, or if people have questions, we can hypothesize about this. But the next study that we're planning to do is to see, is it really that there's differences between men and women, or once we take into account these modifiable risk factors and also the urine values, are there still going to be differences in the rates between men and women? And I hope to have those data soon. So I will stop there and be happy to take questions.
Gary, great presentation. One potential difference is urine pH between men and women, and that could explain the higher calcium phosphate stones in women. I'm not sure if you've looked at it in your cohort.
So we have the absolute differences are about 0.1. So again, unfortunately, we don't have stone composition. More than 80% of both cohorts were calcium oxalate, so we might not be able to detect a signal with that.
It's interesting, with bisphosphonate, you didn't see a decrease in calciuria, you said, right?
We didn't, yeah. So again, when we looked at the 24-hour urines among those who were on versus not on a bisphosphonate, there was no significant difference, yeah.
Because I just looked it up, it was this Italian study, you may know, in NDT published, where they did alendronate and they saw a decrease, but maybe it's...
Yeah. All I can say is ours are observational, so I can't tell whether there's a change. Perhaps that the individuals that got bisphosphonate were different. Since most endocrinologists don't order 24-hour urines, I think it'd be unlikely, but I don't know. I do think if it works, whether it's by lowering calcium or not, I'm less interested, but it'd be nice to see if there was actually good long-term data to see if it actually affects stone risk, but ours are just observational.
Sorry, a simple question. Why are the most diseases in the age are increasing? Why are stone formers less in the age when you get older? Do we have
why does it go down, the stone risk?
Why? Have we some explanation for this? Most diseases are increasing when we're getting older. Why we get less stones when we get older?
Yeah, I do not know the answer to that. We haven't... I guess we should look at the 24-hour urines to actually see how different they are. My guess is, as you get older, your concentrating ability goes down, so my guess is that the urine volume is going to be slightly higher, but I don't think that would explain the steep differences. That's a really good point.
I have another quick question. There's obviously hormonal differences between male and female, and did you have a look in postmenopausal women with and without hormonal supplementation, if you can see differences in stone incidence?
Yeah. So Dr. Prohaska is working on that right now. So we had published on this years ago that we didn't see any difference between pre- and postmenopausal women, but actually in our younger cohort, we actually are seeing a higher risk postmenopausally. And it does not seem to be prevented by postmenopausal hormone use, but the analyses aren't done, but in contrast to what we had seen before, it does seem that there is an increase with menopause. I don't know how long after. I mean, obviously it doesn't go on forever, so I don't know.
Thank you.